Good morning, everyone. I'm thrilled this morning to introduce today's speaker, Beth Zupec-Kania. I had the pleasure of working with Beth back when I was at the Medical College of Wisconsin at Wisconsin Children's Hospital in Milwaukee, and Beth was fortunate for me to be our ketogenic dietitian. And since that time, Beth has become an internationally recognized expert on ketogenic diet metabolic therapies. And Beth has traveled to virtually every country in the world to teach providers on ketogenic diet metabolic therapy, initially for epilepsy, but ketogenic diet therapy has been recognized for helping many other conditions, including cancer therapies, and she's going to speak to us today on psychiatric disorders that can benefit from ketogenic diet metabolic therapy. Beth is a regular leader in the American Epilepsy Society meeting and participates in many organizations around the world. So we're thrilled this morning to have Beth talking to us about ketogenic metabolic therapies for psychiatric disorders. Beth, so happy to have you here.
Thank you. And I have to say that soon after Dr. Wolfong left our facility, I decided to go out into private practice, which is where I was able to kind of spread my wings and travel internationally to train and help write consensus guidelines and so forth. So I'm so proud of the program that they have now at Phoenix, at Barrow Neurological Institute. They're one of the largest pediatric neurology, epilepsy, keto programs probably in the world, definitely in the US. So topic for today is ketogenic metabolic therapies for psychiatric disorders. I have no financial disclosures, and here is my outline. I'm going to go through a little bit of history and some statistics, talk about nutritional ketosis, and then spend the last third of the presentation on practice guidelines to help you if you are going to be involved in prescribing a ketogenic metabolic therapy. And I will use that acronym throughout. So I've really struggled to come up with just a few studies to show you, but there is over 100 years of medical research, and epilepsy treatment was the initial reported application of KMT in 1921 through the Mayo Clinic. There is a pilot trial that was reported in 1965 on psychosis, a clinical trial on obesity, the first randomized clinical trial in epilepsy in 2008, and then in the same year, a clinical trial on type 2 diabetes, a case report on schizophrenia in 2009, a pilot trial on bipolar and schizophrenia in 2018, and then a retrospective study on persistent mental illness in 2022, and the same year, a clinical trial on multiple sclerosis. And then finally, or most recently, a study in 2023 on bipolar disorder. And I'm going to come back to some of those in just a minute, but I did want to mention also this timeline, which is trends in ketogenic research, which have been largely impacted by grassroots efforts of two nonprofit organizations. The Charlie Foundation in 1994 was started by Jim and Nancy Abrams after their son Charlie suffered a year of treatment-resistant epilepsy and then became seizure-free on a KMT. They started the Charlie Foundation to advocate KMT to other families, and they helped fund initial research. Similarly, another nonprofit, the Bazuki Group, was started in 2020 by Jan and David Bazuki after their son Matt, who suffered years of bipolar depression, went into remission on a KMT. They too have advocated to others and have donated to many research trials on KMT for depression. So much of what we've learned in epilepsy can be applied to mental health. We have a 2020 Cochrane Library report that summarized over 13 clinical trials in both children and adults. And their summary was that in a medically supervised KMT, and that's a very important point, over 50% or greater reduction in seizures. And we also now have consensus guidelines on KMT for epilepsy in children and adults as well. So a few statistics on severe depression in our country. Schizoaffective disorder, 0.3% of the population. Schizophrenia, 1%. Bipolar disorder, 2 to 5% of the population. And in this diagnosis, there's a twofold risk of type 2 diabetes, and cardiovascular disease is the leading cause of death, and majority of these people are overweight. And for all of these diagnoses, a large portion don't respond to medication. And that's a pretty big swing in statistics, 30 to 60%. And many of you may know the statistic for treatment-resistant epilepsy is 25 to 30%. So this is an even more, dire diagnosis. Mental health treatment is multifactorial. I'm just focusing on diet and nutrition in this presentation. And I also want to recognize that there are nutrition deficiencies that can be a cause of depression. And I'll come back to this in the last third of the presentation. I want to highlight a couple of pioneers in KMT research. And this is, this is in its infancy. So we are really a small group of people. I've gotten to know the researchers quite well, similar to use of KMT in epilepsy. It's a small group of people that are really doing this to get it going. And Ian Campbell at the University of Edinburgh, Scotland, was diagnosed with bipolar in his late teens, and he decided to try and lose weight, put himself into ketosis, and found out it helped his bipolar disorder significantly. So he went on to get a PhD, and now he's doing trials. And his theory is that ketones mitigate the excitatory, glutamatergic, and glycolytic states that cause mania. So his pilot trial has an early publication, and the website is listed below. And by the way, I'm citing the PubMed index on my slides, and I'd be happy to provide a copy of my presentation to Christina for you if you're interested. Another pioneer in KMT research is Shabani Sethi at Stanford Medicine, and she has coined the terms metabolic psychiatry. And her theory is that ketogenic metabolic therapy improves mitochondrial metabolism, improves neurotransmitter function, and reduces oxidative stress and inflammation. And she also has a pilot trial, and I am the nutrition consultant for that study, and I meet with her patients weekly. This is a retrospective case report series that took place in France published in 2022. They had 28 adults out of 31 actually who completed the trial with medication-resistant depression. They were all admitted to a psychiatric hospital for the entire duration of the trial and placed on a ketogenic diet of 20 grams of carb per day. And the duration of the trial was between 6 and 248 days. They recorded significant improvements in weight, blood pressure, glucose, and triglycerides, and even more importantly, changes in psychotropic medications. So the pie chart is showing you the reduction in medication, 64% reduction in medication, and then the three major diagnosis groups are below with an icon of a person representing each data point of improvements. The gray group is no change, and the yellow group is adjusted medications, and then there was one person in the bipolar group that had an increase in medication. So now there are 13 studies currently in process on KMT for mental health disorders. And many of these have received significant funding from the Zupec group, which I mentioned in my earlier slide. So bipolar disorder, psychosis, major depressive disorder, anxiety, Alzheimer's disease, substance abuse, PTSD, and weight-restored anorexia. So now I'd like to turn our attention to nutritional ketosis, and I'm not going to go into great detail of biochemistry in this short presentation, rather talk more about clinical impressions of ketosis. And it's always good to start off with a definition. So nutritional ketosis is a metabolic state where ketone bodies generated by diet become the primary fuel source for metabolism over glucose. And when explaining this to my clients, I like to use the analogy of a hybrid car, which can use gasoline, and we relate that to glucose, or electricity, which relates to ketones. And scientists are saying that ketones is a much cleaner energy, much like electricity for a hybrid car. So therefore, a ketogenic diet is a macronutrient formulated diet, which causes an accumulation of ketone bodies. And by the way, that's my definition, because I don't see clear definitions in the literature. There are different methods of measuring ketones. Beta hydroxybutyrate measured in blood is what all of the studies use, or most of the studies use. Acetone, which is ketones exhaled from the lungs, is another method. And now there are portable meters for measuring this. And then acetoacetic acid, which is the old school method of measuring ketones in the urine. This is the crudest measure because you're measuring ketone byproducts. So this is past ketosis, and it can be affected by how dilute or concentrated the urine is. But we still use it. It can still be a very helpful indicator of ketosis. What is therapeutic ketosis? We're talking in terms of beta hydroxybutyrate. Therapeutic ketosis would be 0.5 millimoles or greater. And normal BHB in somebody on a high carb diet would be less than or equal to 0.1. So let's look at serum ketone levels under different conditions. So a conventional diet, non-fasted, as I just mentioned, BHB would be less than 0.1. After an overnight fast, it might be a little higher. After a 2-day fast, even higher. Nutritional ketosis, 0.5 up to 6 millimoles. And we rarely see these high levels in adults. In children, much more common, especially at the beginning weeks of the diet. Ketogenic diet with exogenous ketones, 1 to 8. And I'm not going to get into exogenous ketones in any detail because there just isn't much science out there on them. And I do have clients that use them. So I have a little bit of experience, but I'm not going to spend much time going into detail. But these are simply ketones that have been created in a lab that are then formulated into some type of drink, usually a powdered beverage, and they provide an acute and short-lived increase in ketones. And that's what's important to remember, is that they don't replace a ketogenic diet. But I do have people that find them helpful, so I wanted to mention them. And then prolonged fasting greater than 72 hours, we can also see very strong ketones. And then I just wanted to add that diabetic ketoacidosis is another condition. It's a condition of energy crisis where in the absence of insulin, the liver starts to pump out ketones as it breaks down the body's own stores of fat. So this is a condition that is not typical with ketogenic diet therapy, but people need to know about it, especially working in hospitals where you're measuring biomarkers. So I want to turn our attention to macronutrients. These are our energy nutrients: protein, carbohydrate, and fat. And there is a complex interrelationship between these macronutrients, all with the end goal of providing ATP in the mitochondria. So we're going to take these one at a time. The first macronutrient, carbohydrate, is and these are the NIH dietary reference intakes that were last reported on in 2005, but there's no requirement for carbohydrate because they're not essential. But the US dietary reference intake is 130 grams a day, and that's children ages 1 through adulthood. So it's a blanket statement for carbohydrate intake, and that is used by hospitals and food services and schools and et cetera as a guide in meal planning. So it has a strong impact on our everyday life, whether you know it or not, in providing recommended amounts of carbohydrate. So this is not amendable to KMTs. We can't get somebody in ketosis on 130 grams of carbohydrate, and you'll know why in a few minutes. But I do want to also explain that the same recommendations go on to explain the clinical effects of inadequate intake. And I've underlined this statement that I'd like to read. The lower limit of dietary carbohydrate compatible with life is apparently 0, provided that adequate amounts of protein and fat are consumed. And when I read this, I felt completely relieved that I wouldn't get sued for malpractice. I wouldn't lose my license as a nutritionist because of this statement. I highlighted in yellow here that they go on to talk about that there's indigenous populations that live on very low carbohydrate diets with no apparent negative health effect. And even Caucasians in Greenland have tolerated a essentially carb-free diet for a year. So if you're at all involved in social media of ketogenics, you're going to come across a lot of chatter about this. But this is where we kind of start with when we're evaluating macronutrients and comparing them to keto. So then this slide shows you what's really going on in our food culture. People are getting above what is recommended in a single meal. So a fast food meal, 140 grams of carb between the burger, the bun, the fries, and the soda, the sugary soda. And we're teaching people 5 grams of carb in a meal. So this is bun made with egg whites, and water in place of soda, and a little bit of vegetable, and same calories in both of these pictures here. So quite a bit different. And also this highlights the difficulty in getting adults at least to follow low carb diets because they've been accustomed to such high carb intake for so many years. So again, US dietary reference intake is 130 grams per day. So let's look at some glucose curves of consuming carbohydrate. And this is very conceptual. I just created this for driving home the point that simple carbs are like candy, for instance, are absorbed very rapidly into the bloodstream. And complex carbohydrates, because of their matrix of fiber and cells that need to be broken down, like for instance, a piece of fruit, don't create quite the rise. Our second macronutrient, protein, we do have a recommended dietary allowance, and I'm going to just speak to adults because it's a little different for children, and it is 0.8 grams per kilogram minimum. And they go on to say this should be good quality protein. And the AMDR, the acceptable macronutrient distribution range, so this is pretty much saying it's okay to go higher than this, is 1 to 3.7 grams per kilogram. And this is amenable to KMTs. So let's look at our glucose curves with protein added in. So here's our simple carb, complex carb, protein added in. And what protein does is it delays the rise in glucose. And we call that, lowering the glycemic index. So this is why you include protein with each of your meals. And third macronutrient is fat. So there is no recommended dietary allowance for fat, but there is AMDR, acceptable macronutrient distribution range, which is 25 to 35% of total energy for the day. And for a 2,000 calorie diet, I just calculated this out for the sake of understanding the gram amount of fat, 55 to 75 grams of fat a day. And they go on to say a tolerable upper intake level, or UL, is not set for total fat because there's no defined intake level of fat at which an adverse effect occurs. And this, of course, is amenable to ketogenic diet therapies, but nutritional ketosis requires at least 60% fat intake. So that's, roughly double of what the AMDR is. So let's look at our glucose curves with the fat added in. Simple carb, complex carb on their own, protein added into the mix. And then when we incorporate fat, we lower the glycemic index and stretch out the glucose curve over several hours. So this, of course, is all dose dependent, and this is simply just curves to help you understand the combination of foods and also why we provide keto meals in this kind of combination. So I'm going to go through this one more time. Simple carbs, complex carbs. On a ketogenic diet, we minimize complex carbs. We eliminate simple carbs completely if we can. And protein is definitely allowed. Usually it's less than what the individual is consuming. And fat is the main source of calories. So the glucose curve now looks more flat. We don't see these peaks and valleys. We see this flat curve. And again, we teach people to consume fat with each meal. It's really the only way to get this high amount of fat in an entire day. They have to break it up throughout the day and not just consume it in one sitting. So when you start somebody on a ketogenic therapy, you can follow their biomarkers and see their glucose start to come down. And as their glucose comes down, their liver, is burning up all the glycogen that it has available in an adult. That takes about a day, maybe 2 days. The body starts searching for the alternative fuel, which is beta-hydroxybutyrate. And if they're fasting, they'll start making ketones from their own fat stores. If they're eating a ketogenic diet, they're going to start using the fat from the diet. So we use a combination of those methods to get people gradually into a state of ketosis. And then their biomarkers start to plateau out. So that we see this inverse relation: the lower the glucose, the higher the ketones. And in summary, we try to achieve ketosis, but individualize the diet so that we get the person into a state of ketosis that's comfortable for them and that gets them results. And notice I didn't say a degree of ketosis, because that's what everybody asks. What level of ketosis should I be in? It is so individual. We get improvements in epilepsy and migraine and in mental health with different levels of ketosis. So all these years of studying epilepsy, over 100 years of research in epilepsy, we still don't have the magic range of ketosis. But we do have a good indication of when somebody's getting better, and all those clinical measures are important in evaluating if you need to possibly achieve a higher degree of ketosis to get better outcomes, or maybe even lower ketosis to make the person actually feel more energized. So it's very individualized. And for adults, it might be less than 20 grams of carbohydrate a day. I certainly have worked with very active people who are very, very athletic and working out regularly, who can be in ketosis on 50 grams of carb a day. But for most people, it's 20 for most adults. And for protein, the quantity can influence degree of ketosis. Too much can stimulate insulin secretion, reducing ketone production in the liver. And 1.5 to 2 grams of protein per kilogram is typical. And I really specifically chose this statement because one of the biggest mistakes I see in adults who come to me for consultation is that they can't get into the ketosis. They've cut out all their carbs. They're eating very minimal carbohydrate, if any, yet they can't get into ketosis and they're just flummoxed. And what I realize is that they're just consuming most of their calories from protein and not nearly enough fat. So then we work on flipping that. So they're getting more fat energy to make ketones, less protein. Fat is the majority of calories, and the emphasis is on monounsaturated and saturated. And 100 to 200 grams a day is typical. And just as a point of reference, a stick of butter is about 100 grams of fat. And I'm not telling people to eat a stick of butter, but I am telling people to eat butter and olive oil and avocados and these healthy fats. And the ratio, and this is a new term, so the ratio is fat in grams compared to protein plus carbohydrate. And I'm going to get into that a little bit more in the upcoming slide. So the ratio needs to be at least 1 to 1. So we're saying about equal amount of fat in grams as protein plus carb combined to get into ketosis. So these are the ketogenic metabolic therapies used in epilepsy, and they've been well published. And Lisa and Christy know these inside and out and backwards and forwards. And what we do, we know we have these variations in diets available. And what we tend to do is start off by individualizing what the family will need and giving the family an option. Some families prefer the old-fashioned classic ketogenic diet. You can see the little scale above the picture. Foods are weighed on a gram scale, every single meal, every single snack. It's a lot of work, but I'll tell you what, it works. We get good, consistent ketosis, and we can modulate the diet if we need to for stronger ketosis or lower ketosis based on the effect. And this is primarily in children, because look at the green pie chart on that first box on the left, 90% fat. That's the classic ketogenic diet, 90% fat. I mean, it sounds impossible, and it is doable. It is an inordinately small amount of food. Grandparents just flip out when they see their grandchild eating this, but it's very effective in getting into ketosis. And children are on ketogenic diet therapy temporarily. It's usually a year up to 3 years. Most children, some are on much longer, but the majority of children are on it for a short period of time, so they can handle this. And the other thing is that we tend to start off with a strong ratio and then wean them down from that ratio over time, less fat, more protein, more carb, and modulate the diet until they're out of ketosis, which is the end goal, is to get them off the diet eventually. The second box is the MCT oil diet that was designed by Peter Huttenlocher at the University of Chicago in 1971. That is this 1-to-1 diet. So there's about equal amounts of fat and protein to carbohydrate. You don't see that on the plate because the plate is representing percentage of calories. So it's a lower fat diet, but the main oil used in this diet is medium chain triglycerides, which comes from coconut oil. And it's high in these medium chain fats, which are converted more easily into ketones. So it's a more ketogenic diet, which allows it to be lower in fat, which gives you more carbohydrate and protein. The problem is hardly anybody can tolerate it because the oil has such a strong laxative effect. The very first patient that I worked with came to me on the MCT oil diet, and I had to learn quickly, first of all, but get him off of the MCT oil or reduce it significantly and get some other fats into his diet so that he could tolerate it. We do, however, like to use that MCT oil because we know it is so ketogenic. We use that in all of the other therapies. So that's been a very helpful diet to learn to use in other therapies. And we still use the MCT oil diet, particularly for people with feeding tubes, where we can blend all of this into a formula and the person is not tasting it. So it also uses a scale, or it can be measured in household measure. And then the two boxes on the right are representing the more hybrid, the newer ketogenic therapies, the low glycemic index. In 2002, Heidi Pfeiffer, a dietitian at Boston Children's, designed this as a pre-ketogenic start diet for people who are waiting to get admitted. This is children specifically. And what they were finding is that they were starting their kids on this diet, preparing to be admitted, and seizures were improving significantly. So they began to using this as actually the first trial of diet, and then going to a classic ketogenic diet if needed, if seizures still persisted and the parents wanted to get a little stricter. And then finally, Modified Atkins designed or actually published, he didn't design the diet, but he published it in 2006, Eric Kossoff at Johns Hopkins, about a 1-to-1 ratio. This is intended for adults, quite loose guidelines, and often used as sort of a start diet and a place to get going where you don't have to measure or weigh foods. You can kind of estimate, and it's been studied as well, and available as mostly for adults. Some teenagers I know also are using it. We tend to use the more restrictive diets in pediatrics, but I have plenty of adults who choose to use the restrictive diets that I just described to get going. And then once it becomes a little bit more intuitive, they kind of relax away from weighing or measuring food, and they've got it figured out. So these are very helpful, again, for use in other applications and in mental health. And that ratio is to really moderate your ketosis. So in the 4-to-1 diet, the 90% diet, you're going to see more ketones than the 1-to-1 diet. And ketosis modulation can be quite effective particularly for epilepsy. We do this less with mental health because we're using more liberal diets, and we don't even know what the ratio is. We're just kind of fixing things as we go along, or trying different things as we go along, because people really are using a liberal estimation approach. So just going back here to the ketogenic ratio, I want to show you the difference between a 4-to-1 diet on a plate and a 1-to-1 diet using salmon, broccoli, butter, and olive oil, and then cream. And the 4-to-1 diet on the far left is a 90% fat diet. So you see cream and olive oil and a very little piece of salmon. And the broccoli remains about the same throughout here, but the big difference is less fat, more protein. So these 4 plates have the exact same amount of calories, but the ratio is different, meaning the fat and the protein and the carbohydrate are different. And they induce different degrees of ketosis. There are different methods of achieving ketosis. So now you know about KMT. We have fasting. Some people have endogenous fat that they can use, and exogenous ketones, which I mentioned a little while ago. So we can incorporate all 4 of these into a plan. And I do this a lot more with adults than with children, who pretty much we just use KMT for children. But adults have the option to use fasting. I wouldn't recommend fasting for any child, except maybe 12 hours of fasting overnight, which is, common and typical. But adults are very open and willing to try these other methods. So what about practice guidelines for mental health? First of all, you have to know that there are contradictions. There are absolute contraindications, and many of these are rare genetic abnormalities, and there are relative contraindications. I have pregnancy there now. Pregnancy it's not recommended that someone would start a ketogenic diet therapy, but a woman with epilepsy who becomes pregnant can certainly continue on ketogenic therapy throughout the pregnancy. And there are published reports that have explored this and created some kind of a basis for guidelines for using keto during pregnancy. Inadequate social support. This is, of course, very concerning, and one of the screening tools that we need to use in order to make sure that the person is safely being managed on a ketogenic therapy and will come back for appointments and blood work. And then the third point, underweight related to cancer cachexia or anorexia nervosa. So I just want to say the caveat with anorexia nervosa is that keto can be used, and I'm one of the consultants for a small pilot trial in anorexia nervosa, and these were all weight restored women, so they were not underweight. They were actually at the bottom of the BMI as a minimum for the screening criteria, and we were able to show some improvement in women who had tried everything else. Again, these are treatment resistant, and just like all of the other conditions I'm talking about, treatment resistant, and so KMT becomes alternative therapy. And then finally, medications that require close monitoring, SGLT2 inhibitors, vitamin K coagulant therapy, and diuretics.
And they received support, but they were not defended.
Matt, can you mute yourself? Okay. And then, of course, we need to talk about potential adverse effects. Constipation can be an adverse effect. I have a lot of people that actually have improvement in bowel management, and because it's one of the first things that I talk about. Electrolyte imbalance, carbohydrate is like a sponge, as I explained to my clients. It hangs onto fluid, and when you're not consuming carbohydrate, you don't have that sponge effect. So you need to drink fluids, and you need to salt your foods. Medication toxicity can be possible, carnitine deficiency or insufficiency. And then the last one, which I think is most concerning to people, is what about elevated cholesterol and LDL? And I'll come back to that. And positive changes, I want to also like to mention that right after the adverse effects, because people start getting scared. But many people, and I would say the majority of people that I work with, report better sleep, better energy levels, no afternoon crash, gastrointestinal, less gas and bloating, stronger nails, improved skin, acne and resolution of eczema, and calmness. That's one of the early signs that I get from people with major depressive disorders, that they feel calmer. So there are pre-keto laboratory tests at baseline. We like to get a fasting level of CBC, complete metabolic panel, fasting lipids, including the NMR, ApoB, ApoA, vitamin D level, uric acid, insulin, B12, and folate, and total and free carnitine. So this list came from Metabolic Mind, which is an affiliate of that Bazuki group. And we have a group working on consensus guidelines that will be coming out later this year. So this same list will be published in that group. And then these, this list is optional. And these are looking at some of those vitamins I mentioned earlier that can be causative of depression. And so we list these as optional. And what about heart disease? So I have to remind even my nutrition colleagues that in 2020, the American College of Cardiology came out with a statement that whole fat dairy, unprocessed meat, and dark chocolate are saturated fatty acid-rich foods with a complex matrix that are not associated with increased risk of CVD. And the totality of available evidence does not support further limiting the intake of such foods. So that really exonerates saturated fat. And then there's new keto research. And now this sounds very provocative, but I put this in quotes, so see I missed my end quote there, but this is exactly what the early report of this research is showing, that there's no relationship between LDL-C elevations and plaque formations. And this is specifically in people following a medical ketogenic diet therapy, okay? Not somebody on a high carb diet, all right? So that trial is going on right now. So nutritional ketosis has many effects on the body. There's an enhanced energy metabolism in mitochondria, reduced excitability of neurons, healing of myelin. It has an anti-inflammatory effect on the brain, changes in gene expression. And this number 6 is a newer finding. Ketones act as signaling molecules. Additional benefits, there's an alteration in gut microbiome. This is where the majority of neurotransmitters are made. Keto restores satiation, which leads to periods of gut rest. That's something that also is reported, particularly in people that are overweight. They finally feel satiated and they're not hungry all day long as they were before. Restoring insulin sensitivity, enhancing awareness and cognition, and stabilizing mood. So these are just from a couple of research articles that I pulled through to share with you. And then considerations in mental health. Medications must be carefully monitored by a physician. We need to talk about deprescribing medications eventually. That's very difficult to do. This is something that parallels epilepsy. One thing that people ask at the beginning is, will I be able to get off of my medications? And the answer is, well, not initially. You know, we don't know if this is going to work, but given time, and you want to give it a couple months at least, maybe even 3 months. We say 3 months for epilepsy, and now we're learning through our early work in mental health. It's also about 3 months, 3 to 4 months before we see true positive, consistent changes. So we don't want to start prescribing medication too soon. Hypomania is a potential in bipolar disorder when starting keto, and it might be attenuated with slow startup. So I'm used to slow startups working in private practice where I'm not anywhere near my clients. Some of them are, you know, halfway around the world. And I'm also worried about liability. So I do very, very gradual startups. I have not seen a case of hypomania yet, but it's, you know, I haven't done that many. Looser diet than for epilepsy, that we know is probably true. I have people that have been in remission from bipolar disorder for a while, a couple of years, and they have cheat days. And as long as they get back into ketosis the next day, they seem to be okay. But having said that, I also have heard stories of people who cheat and then have an episode the next day, or just feel terrible, like they have a hangover for the next day or two. So consider the emotional situation. Are there caregivers? Start simple. I'm going to come back to start simple in a moment. And then other comorbidities. I mentioned cardiovascular disease, obesity, diabetes. Keto can actually improve those too. And then monitoring. I find people do better when they are monitoring. And I like to monitor both glucose and ketones. Some people will just do ketones, but I'm an old school practitioner. I like doing both with adults. And I find that those that are able to do both actually do better. So in summary, KMT therapy is a 4-step process. There is a screening and assessment, including an intake. And this is, I'm talking in terms of either my nutritional intake, or for the psychiatrist, this is their intake that they do to get a history. Laboratory studies, you want to rule out contraindications, and also to evaluate nutritional status, and then ensure a social support system. And then step 2, ketogenic diet therapy preparation. I talk to people about eliminating sugar from their diet, medications, and supplements. And that's hard for them to do. It's also a test. If they're not able to do that, they're not likely to be able to follow a ketogenic therapy. Number 3, which diet and how to initiate. And number or management and follow-up care, where you personalize and adjust the therapy to optimize outcomes. And lots of education to the caregiver or the individual themselves. And for mental health, I'm usually dealing directly with the individual. There are no caregivers, and usually this individual is really on their own at home and making meals. So there's some KMT dietary support apps available. Keto Diet Calculator is a program that I designed that is the old school weighing food on the scale, largely used with children or people with enteral feeding tubes. Chronometer is a keto tracking tool. And this, there we go. Flexible macronutrient distribution. This is kind of like as you go through your day, you're entering the foods and getting a tally of your macronutrients. We can make modifications. These are different dietary patterns. Remember, I told you that keto is a macronutrient formulated diet, but we can apply all these different dietary patterns. I don't have all of them here, but this is the more common ones. And then Lisa and Christy are pros at formulating keto for enteral feeding tubes and parenteral nutrition, right? So we also need to provide those. And this is what we nutritionists refer to as well-formulated ketogenic diets. If we could have our way, everybody would eat real food all the time. And that doesn't happen in the real world, but that's what we teach people to strive for. This is also similar to the handout that I use when I talk about start with simple keto. We talk about just macronutrient groups. So these foods can be, they're the highest, the fat group has olive oil, coconut oil, and butter in it. And carbohydrates are low carb vegetables and a few fruit. We talk about avocados and olives being the best keto fruit, right? And then, of course, protein-rich foods, which are mostly animal fats. I do have a vegan protein source there. It's hemp seed, which is the highest protein, lowest carb vegan source of protein. So what I tell people to do is just eat something from each of these groups. There's only 3 food groups, right? Eat something from each of these groups at each meal to get you going. And then we'll talk about that after about 2 weeks. So that's while we're waiting for their blood work to come back and setting up an appointment to chat about which diet they're going to use. This is how they can start out. And so I'm looking at the time here, I'm doing pretty good. I have a patient who's given me permission to share her history with, and I've been working with her for a little over 3 years. She was diagnosed with bipolar 1, anorexia nervosa, and autism starting at age 15. She was on multiple treatments, hospitalization. She didn't even know how many hospitalizations, and sometimes in the hospital for months at a time. I had her, send me pictures of her, where did they go? Her favorite meals. And sorry, I keep moving our pictures out of the way so I can see my slide. Her favorite meal is pancakes, which are made with almond flour and eggs. Eggs are the main ingredient. And she drizzles a lot of fat over those and no syrup, of course. And then this is her favorite take to work meal. This is a salad with a packet of salmon. And then she's got a cup here with olive oil and a little bit of vinegar. So that's her favorite go to work meal. So she was highly motivated to start keto. I finally met her in person at the Global Symposium a few months ago. And she works as a career counselor in a federal prison. And she told me that keto has allowed her to function and keep her job. So her motivation was just have a job so she can afford to live in a decent apartment and be, a functioning person in society rather than be on disability, which she was really facing a decision that she might have to do that. And so that was her motivation. And she's been a pleasure to work with. And we've had lots of ups and downs in trying to find what works for her. But we talk about her ketogenic lifestyle. So it's not just the diet, it's managing her hydration with electrolytes. We've got her on some supplements. She's doing a little bit of intermittent fasting. And then we're talking about, how long am I going to do this? And she's pretty much decided it's her lifestyle, because she's tried to come off after a year, after 2 years, and all of her symptoms come back. So she's resigned to staying with this therapy for the long haul. So personalized management of KMTs really that's the new practice on the horizon for all of us, looking at genetic variants, looking at those single nucleotide polymorphisms. And this meta-analysis found that there were SNPs associated with positive outcomes of using keto in weight loss, in epilepsy, and even cognitive gains in Alzheimer's. So that's the future of medical practice, is figuring out what therapy works for people, right? So I just had to throw that in there. And then finally, consensus guidelines for ketogenic diet therapies are in development for mental health. These should be out by the end of the year, and I'm one of the authors. And then my last slide is just sharing some of the great resources on the Charlie Foundation website, including these recipes, which you can find by clicking on the recipe link at the top of the page. So I think we've got a few questions in the chat here. Or those are announcements. I see Lisa is here. Lisa, do you have some questions?
I have a question, Beth. Thank you for
Okay.
a wonderful talk. It was really very, very, very exciting. I was wondering when and if this becomes mainstream, how is the dietitian community going to deal with all the numbers, keeping it medically supervised and safe versus the Costco book version of the ketogenic diet? I mean, I imagine the numbers are going to be overwhelming.
Yes, so that is one of my charges, is to train dietitians, and I've teamed up with Denise Potter in doing virtual trainings for dietitians. So we used to go into hospitals. We've gone into over 300 hospitals over the past 15 years, and with COVID, we couldn't do that. So we created a virtual platform, and now we're training dietitians online. That's one way. What is so cool about training dietitians is if you train one in a hospital, they'll train the next one, and that one will train the next one. So you really only have to do the training once. And that's the good part. The hard part is getting payment, getting reimbursement, right? That's always the stopgap in getting therapies into hospitals. So there's some effort in the dietetic community to start covering this type of therapy, but it's not going to happen until there's large numbers of, like, for example, I tried to get practice guidelines through the Dietetic Association, and what they came back to me with is epilepsy is only 1% of the population. We're working on diabetes, cardiovascular disease, and renal disease, which are much bigger. So now that mental health is on board and these consensus guidelines are out, I'm going to be able to go back and say, all right, now let's talk. So that's another piece of it, is getting buy-in from my academy to start going for reimbursement codes. And that takes, that's legislation. So we're working on it, and hopefully it'll happen. Oh, somebody noticed my gloves. Yeah, it's a little cool here in Wisconsin. Thanks, Matt. Yes, I can provide a PDF of my slides. I'll send that to Christina, and she can make that available to you.
Hey, Beth,
Anybody?
fabulous presentation. It was really awesome. I'm just reflecting on some of the challenges that must face our mental health colleagues and you and your colleagues in prescribing ketogenic metabolic therapy. Many of the psychotropic medications are weight gain drugs and appetite stimulating drugs. It must be a particular challenge to introduce a calorie reduction diet in the face of those medications.
It is, and I know a psychiatrist who is actually using metformin as a first line. You know, if somebody comes to her and has tried various medications and they're considered treatment resistant, and she'll talk to them about keto metabolic therapy, but she'll say, before we do that, I want you to have a trial of metformin. So that's Shabani Sethi. I mentioned her as a pioneer. But yes, the other medications like is it GLP-1? Am I pronouncing that right? GLP-1 in.
Yes.
Yes. So those actually are considered fine to use with keto and maybe used at the beginning. I know a psychiatrist who's using that approach. So what we see is that once people start feeling better because they are losing weight, they're more inclined to follow a restrictive diet. So I think those approaches are worthwhile.
That's great. And just one other point on that, you mentioned it briefly, but you know, we're always concerned about children cheating on the ketogenic diet or stealing fridge or food-seeking behavior, or going to a birthday party and having a piece of cake, and suddenly getting kicked out of ketosis and triggering seizures or even status epilepticus that could potentially be life-threatening. Is there that similar risk of suicidality or some other terrible outcome in the mental health world if they stray from the diet after being ketotic?
There certainly is. And I have not seen that in my clients. Again, I have a less than 30 clients that I've worked with severe bipolar disorder. But I do know about that through mostly Chris Palmer, who has seen, you know, hundreds of patients on keto therapy over the years. He's reported this. I think Matt Bernstein is a psychiatrist in Boston. I think he's found a really great solution. He is opening an inpatient clinic in Boston. I'm a consultant for this clinic, but they're bringing people in and it's only for keto, and they're starting them up gradually according to my protocol that I've used, and they're keeping them for a month. And, you know, managing medications and so forth, and really doing all of the diet preparation work so that they don't have to worry about that. So they're just eating, and then eventually they're taking on those roles of learning their diet. And then they have the option to stay another month if they want to. So he's also, the Buzuki Foundation is helping sponsor this. And so he's also doing a bit of research so that we can learn more about these events of, you know, how risky this is. Do we have an emergency system in place when somebody does go cheat? And I didn't really go into this, but I mentioned exogenous ketones, and this is where some of my clients have used exogenous ketones when they have cheated, and this is usually on a weekend when they're out socializing, then they decide to have a cocktail, and then the cocktail is followed by high carb foods. And then pretty soon the next day they are in the slump. This is when they have used exogenous ketones to help them recover from that acute state. Adrian, I see your hand up.
Yes, good talk as usual. You mentioned cachexia in cancer patients as a potential reason not to use keto, and I'm not sure I would totally agree based on the literature I've seen, because the keto is an anti-cachexic diet. It's anti-inflammatory and it's anti-muscle wasting. So in fact, in addition to all the other things it does to help cancer patients, potentiate therapies, all of that other good stuff, it may actually help to prevent or at least reduce cachexia. And all of this, of course, is predicated on what you said, and that is that it's got to be, of course, done by a dietitian who can prevent weight loss. But weight loss in a cancer patient on keto is, from everything I've read and heard, is typically not cachexic weight loss. It is fat weight loss, and that's very different. So just a comment.
Yeah, thank you for that. I have worked with a couple of people with very advanced cancers. They had feeding tubes and they were struggling with cancer cachexia, but because they had feeding tubes, it didn't matter what their appetite was. They were able to get their nutrition and they were able to, I got them to gain weight. So I have concerns about people that just have no appetite because of their severe malnutrition. So that's why it's one of those relative, it's not a contraindication, but it's relative. Like somebody's got to watch these people.
Sure. And again, that comes down to what I tell cancer patients contact me all the time. And the first thing I tell them is I'm not a physician. And the second thing I tell them is I will give you the names of dietitians and you must deal with them. And you must tell your physician you're doing it. You know, that's for exactly the reasons you said. The other quick comment I would have a question is to get the Dietetic Society to be more interested. You know, they mentioned diabetes, but keto is being looked at and being used by diabetics successfully. So would that be I'm sure you've thought of this, would that be a hook to get them to like start to think about this?
Yes, well, the American Diabetes Association for the first time recognized keto as a, as a therapy that could be tried.
Yay!
Yes. And so, I mean, that just happened. And that's really been the result of the Virta Health project, which is now, in my insurance provider now provides Virta Health free. And this is, for those not familiar, it's a virtual health platform for people with diabetes. And you get coaching, you get a dietitian, you get a psychiatrist, and you get all kinds of guidance to control your diet, manage your diet, and the whole goal is diabetes reversal. And this is for type 2 specifically, type 2 diabetes. So it's been, the Virta Health research is really well done. Jeff Folick is a dietitian with PhD who actually masterminded the program, and it's really changed the way that type 2 diabetes is being looked at, not only from a treatment standpoint, but even preventative.
Yeah. One more real quick question. So for otherwise healthy people that are interested in doing keto for weight loss or for general health, there's some athletes for sports, things like that. It's impossible, as far as I know, to get, unless you pay a lot of money, to get continuous glucose monitor if you want to just follow what's going on to be healthy. Do you know if that's changing at all? The idea that a healthy person might actually want to watch their glucose.
So there is a company who is going through FDA approval right now for over-the-counter continuous glucose monitors. And that, I think that'll be out by the end of the year.
Great, thank you.
Anybody else?
I think Dr. Kruger has a question in the chat.
Oh, okay.
I can read it for you. It says, did you find it?
I did find it.
Okay.
You mentioned exogenous ketone use after cheating. Does it help kickstart ketosis? Yeah, so here's the thing with getting ketosis going. I really believe in gradual adaptation to ketosis because people just feel better. There's something called keto flu, and I didn't go into it, but it's real, and people can feel sick and awful for 2 weeks, and it's enough to make them just quit the diet. And usually it's because they've gone too fast. Like this is going to sound terrible, but the men that I work with just like stop eating carbs that day. I talked to them about it, and the women tend to be a little bit more, all right, I'm going to cut back on fruit. So it just happens so often that I feel like I can categorize them. And I really want people to go slowly. So the method that I use for startup is that we just switch over one meal at a time for a week. So this week, you're going to eat all your usual stuff, but we're going to switch your first meal of the day over to a keto meal and keep everything else the same. And then we do, you know, each week we work on the next meal. And so that they do go into ketosis gradually and they avoid those keto flu symptoms, which can be horrible. And they're checking glucose all the time. So using a ketone, exogenous ketone during that process, you know, would probably give them a little sense of false hope that, oh, my ketones are up. Now I can eat a little bit more carb, you know, in the beginning. So I haven't used them. So I'm going to say from my experience, I don't find that helpful. And then Rochelle, hi, Rochelle. Rochelle is testing my keto diet calculator for upgrades. Hi there. We're about to go live with a huge upgrade to the keto diet calculator program, which has taken over a year and about $80,000, which I have to plug the Bazuki Foundation for providing that donation. So you can see that they have really made a lot of things happen in this field of mental health and keto. Okay, anybody else? I think that's it.
Thank you so much, Beth. This was a great presentation.
Great. Thanks so much, Beth. It was really wonderful.
You're welcome.
Thank you,
Pleasure
Beth.
to. Yeah. Take care, everyone. Have a wonderful day.
Okay, thank you again.
Bye.
Bye.